Today we're going to be discussing Chapter 18, which is personality disorders. This will be part one of a two-part series going over personality disorder and just the general overview. Part two will discuss each disorder more in depth. Key terms that your book suggests that you understand to make this content easier. Learning objectives from your book. So, what is a personality disorder? A personality is an ingrained, enduring pattern of behavior and relationships. It includes perceptions, attitudes, and emotions that remain constant across situations. Personality is not easily changed, and individuals are often aware of their own personality. Influences of personality come from biologic and genetic factors, as well as our environmental interactions. Personality disorders are diagnosed when personality functioning is impaired and traits become maladaptive. Individuals may exhibit identity problems, including egocentrism and self-centeredness. Their self-esteem is derived from a power of pleasure, often at the expense of others. Behavior does not conform to cultural, social, or legal norms. They could be motivated by personal gratification, often leading to dysfunctional relationships. Relationships that they have are usually some deceit, some coercion, or intimidation. Clients may lack empathy, remorse, or concern for others, and they're not typically capable of mutual intimate relationships. And personality disorders, just like any disorder in mental health, needs to impair the client's ability to function. So a lot of these disorders, you might see examples of it in yourself, in people you know, in people that you encounter. Just because we might have some of the traits doesn't mean that we meet the DSM-5 diagnostic criteria for that disorder. So when we talk about maladaptive or dysfunctional personality traits and personality disorders, some maladaptives could be negative behaviors towards others, like being manipulative, dishonest, deceitful, and lying. We might have anger and hostilities, irritable moods, moods that are labile, they fluctuate, lack of guilt or remorse, which might be seen like as if they're emotionally cold or uncaring, impulsivity, distractibility, poor judgment, irresponsibility, where they're not accounting for their actions, high risk taking, thrill seeking behaviors, mistrust, exhibitionism, entitlement, dependence and insecurity. And with diagnosis of these, it's really challenging because not all traits are present in every single individual with a personality disorder. One main thing is that personality disorders cannot be diagnosed until you're at least 18 years of age, because as a child grows and learns, and we go through periods of child and adolescent, we do have periods where some of these maladaptive behaviors are kind of normal. It's normal that a younger child who hasn't developed their sense of being able to see beyond themselves, they might have entitlement, and that's completely normal. But once they go past it and they go through those different stages, then they should be able to see beyond themselves. Medications are not going to alter the personality. For all personality disorders, it's really therapy that's going to be the key treatment regimen for them. However, just because you have a personality disorder doesn't mean that you won't have anxiety or depression or something else that we will medicate for. Personality disorders are very difficult to treat, and they're very frustrating for caregivers, families, and friends. And again, a lot of them coexist with other mental illnesses. So we have a few clusters. We cluster personality disorders into three. So cluster A, we consider these to be our odd or eccentric behaviors. In cluster A, we have our paranoid personality, our schizoid personality, and our schizotypal personality. The next cluster we have is cluster B. These are going to be your erratic and dramatic patients. And I have antisocial personality and borderline personality highlighted here because those are the most often seen clients in the healthcare systems. These clients typically borderline personality, very high for suicidal ideations and suicidal attempts. Antisocial personalities, these are kind of like our criminals. We see these guys very often in our jail settings, brought to the emergency room by police. So those are your two most commonly seen. And then in this cluster, we also have histrionic and narcissistic personalities. In our cluster C, we have our anxious or fearful behaviors. So these are going to be our avoidant personality disorder, dependent personality disorder, and obsessive personality disorder. Now, obsessive personality disorder is not to be confused with OCD. It is something completely different. There's also other cluster behaviors that kind of relate. So one of them is the depressive behavior. Pervasive pattern of depressive thoughts and behaviors can be seen in various contexts. It's more common in individuals with a family history of major depressive disorder. Individuals with this depressive personality often seek treatment for their distress. We can also have passive aggressive behaviors. These are going to have mood fluctuations that could be rapid or erratic. They may appear cooperative and integrating, but they're also sullen and withdrawn. They usually are easily upset and offended by circumstances. And those don't fit into clusters. So the onset of the clinical course, all right, prevalence, about 10 to 20% of the general population. It's thought in the prescribing world that more people probably have personality disorders, and they're just not diagnosed. We find them more often in lower socioeconomic groups and disadvantaged populations, like our prisoners and substance abuse cases. 50% of psychiatric inpatients have a primary diagnosis of personality disorder. 40 or 45% of individuals with major mental illness have a coexisting personality disorder that typically complicates their treatment. 30 to 50% of mental health outpatients have personality disorders. And this is all data from your textbook. Clients with personality disorders offer higher risks and complications. They have increased mortality rates, particularly due to suicide, accidents, and emergency department visits. They have higher rates of separation, divorce, and child custody disputes. There's also a strong correlation with some of the personality disorders and criminal behaviors, alcoholism, and drug abuse. Treatment challenges, they're often labeled as treatment resistance, and that's due to the deeply ingrained personality traits and behaviors. Change occurs very slowly, which makes it frustrating for the client, the healthcare provider, and families and friends. Many individuals do not recognize their behavior as a problem. Often they may view their behavior as an actual strength. Like they might see belligerence and perceive it as just being really assertive. Attempts to modify the behavior can be seen as a threat by the patient rather than an opportunity for growth. The long-term course symptoms persist through young and middle adulthood, but diminish around 40 to 50 years of age. When we talk about antisocial personality disorder, criminal behavior decreases, but typically substance use and disregards for other people persists. Borderline personality disorder, it's projected that around age 50, they're less impulsive, they have more adaptive behaviors, and they start to have improved relationships. And that's noted with these guys even without treatment. Our schizotypal, avoidant, and obsessive compulsive disorders tend to remain stable throughout their life. So our etiology of personality disorders, there's some biological theories and there's some psychodynamic theories. So when we look at biologic theories, we're looking at personality development resulting from hereditary disposition and environmental influences. Temperament refers to the biologic process influencing sensations, associations, and client motivations. We consider genetic factors to account for about 50% of our temperament variations. We have 4 temperament traits. We have our harm avoidance, which is like high, fearful, social, inhibited, anxious, pessimistic things. When clients have low harm avoidance, they're kind of carefree, energetic, outgoing, and very optimistic. So when we have maladaptive forms, we can have excessive anxiety, or we can have unwarranted optimism. We have some, the second one of those temperament traits would be novelty seeking. So if we have high novelty seeking, we're going to be quick tempered, impulsive, easily bored, kind of disorderly. And if we're low, we're going to be frugal, reserved, um, and more monotone. The third would be reward dependence. This is if it's high. If you have a high reward dependence, you're going to be kind of sensitive, sociable, and dependent on approval. If you have a low reward dependence, you're going to be aloof, socially detached, and kind of indifference. The final one is persistence. So people who are highly persistent are going to be hardworking, they're going to be ambitious, and they're going to persevere despite of setbacks. If they're low on persistence, they're going to be easily discouraged, inactive. They might be a little erratic in behavior. A combination of all these traits aligns to create whatever specific personality disorder they have. So when we look at antisocial, these guys are going to have low harm avoidance, high novelty seeking. An avoidant personality disorder might have high alarm, high reward. And then we get into our psychodynamic theories. So this is a theory that personalities are shaped by our temperament, which is our inherited traits, as well as from social learning, culture, and life experiences. So the 3 major character traits influencing personality with this would be self-directedness, cooperativeness, and self-transcendence. So when we talk about self-directedness, if we have high, this is going to be a very goal-oriented, responsible, self-confident person. If self-directedness is low, they're going to blame others. They're going to be unreliable and kind of helpless. Cooperativeness. Somebody with high cooperativeness is going to be empathetic. They're going to be tolerant. They're going to be compassionate. If it's low, they're going to be self-absorbed. They're going to be critical, and they're going to be unhelpful. With self-transcendence, if we're high, we're going to be spiritual, humble, and accepting. Low, materialistic, controlling. We're going to struggle with loss. Character, as we mature, our character kind of changes, and what we are as an infant is not what we are as an adult. When you look at Erik Erikson's and his developmental tasks, if a child is in that, let's say, infancy stage where we're looking at trust versus mistrust, if they don't develop trust, this can lead to lifelong difficulties in relationships and coping. So that's another element within the psychodynamic theories, is that as you're going through your developmental stages, if you don't meet your task, you're going to have a negative outcome with it. If you meet your tasks, you'll have a positive outcome. And then a final theory would be the family and social environment, which can either support or hinder our development. So again, that kind of aligns with Erickson's, your family, your caretakers should be the ones helping you to progress through trust versus mistrust and autonomy versus shame and doubt. And if they're not progressing through those, then we're going to have negative effects. So, personality, in summary, personality is a combination of inherited temperament and it can be influenced by environmental factors. Clients that have personality disorders arise when maladaptive traits become rigid, inflexible, and dysfunctional. We always need to make sure that we have our cultural considerations when we're caring for any of our mental health clients, really for um, any client, patient, family. You want to make sure that we're doing a cultural consideration. So, cultural considerations and personality disorder diagnosis. Remember, ethnicity, culture, social background, all has to be considered. Clients that are defensive or guarded behavior can be seen in our minority groups, our immigrants, and our refugees. And this could all stem from language barrier or past trauma and not really be a personality dysfunction. When we think of things of like religious or spiritual belief, remember some religions believe in speaking in tongues and clairvoyancy and belief in evil spirits. All of that could be misinterpreted as a client that has schizotypal personality disorder, when in reality, it's within their social cultural norm. Cultural difference in social behaviors. We might see a passive, polite woman and think that she's avoidant personality disorder. We could see somebody that has a strong work ethic with high productivity as obsessive compulsive personality disorder. So we just need to know, is this truly a disorder or is this their social cultural norm? Um, there's also some gender biases in diagnosis. Antisocial personality disorder seems to be diagnosed more in men than in women. Borderline personality disorder is more common in women. There's a lot of social stereotypes about gender roles and how that can influence clinical judgment. So, with culture, to conclude, culture norms must be differentiated from pathological behaviors to avoid misdiagnosis and bias. Clinicians must recognize the impact of social and cultural factors on personality traits and behavioral traits. What's our treatment? So, treatment options for our patients with personality disorder, it really needs to be a comprehensive treatment approach. Treatment varies based on the disorder type, the severity, and the level of distress and impairment that it has. Usually, we're going to do a combination of therapy that's going to be more effective than single treatments. However, many individuals do not seek treatment, especially those with schizotypal, narcissistic, obsessive compulsive. Those guys usually blame others for their problems. So, again, schizotypal, narcissistic, and the obsessive personality disorders are the ones that are going to blame others for their problems. They're not going to be able to see that it's, their personality and their rigid inflexibleness. When we talk about psychopharmacology, medication targets the client's symptoms. It's not going to target the personality disorder. So if we have somebody who's maybe having some aggressive and behavioral dysfunction, let's talk about like the antisocial patients, right? They're sometimes thought of as the criminals, right? So if they're a criminal and maybe they're having some impulsive and aggressiveness, we might be giving them antipsychotics. We might be starting them on lithium. Um, on our aggressive and behavioral dysfunction, we do not want to use substances that have the potential for abuse. So you're not going to want to use benzos for those guys. If we have somebody who maybe has cognitive perceptual distortions like magical thinking, odd beliefs, or paranoia, we can treat those with low dose antipsychotics. If we have some type of mood dysregulation, affective dysregulation, so emotional instability, depression, detachment issues, we might give them some SSRIs, some mood stabilizers, or even atypical antipsychotics. Clients that have like a lot of anxiety-based stuff, we can treat that with SSRIs and MAOIs. So again, key takeaways, treatment is focused on the symptom rather than just the disorder. So if you are an aggressive personality disorder, we're going to give you that antipsychotic and it's going to reduce your aggressiveness, but it's not going to fix that underlying personality. So medication is used for symptom, and it's needs to be used alongside therapy, because therapy is what's going to help change those rigid thinking processes. Some individuals resist treatment due to the lack of the insight into their condition, or the unwillingness to accept that it is a personality disorder. And clinicians should avoid over-reliance on benzos due to the addiction risk. So this is more about treatment of the individual group and psychotherapy for them. Therapy approach and effectiveness. Therapy can be effective. So therapy is going to help build trust, teach them basic living skills, provide emotional support. The emotional support is going to help them with their symptom management. So it's going to help reduce anxiety and distress. If we have a client who maybe is a little borderline and we're worried about suicidation, these clients might require inpatient hospitalization. So we need to be mindful, just like any other mental health disorder. We need to make sure that we're treating them the most holistic way possible, and safety is always very important. So with these clients, sometimes we'll use cognitive behavioral therapy. And what cognitive behavioral therapy does is it does, we can call it thought stopping, where it interrupts negative thought patterns. It provides positive self-talk, which replaces that self-critical message with some positive affirmations for them. And it also reduces decatastrophizing, which a lot of these clients will, if you tell them about something, everything will turn into a catastrophe. So decatastrophizing encourages them to have realistic thinking instead of assuming the worst. A good example of catastrophizing would be, my boss wants to see me in the office and I know I'm going to get fired. And once I'm fired, I'm not going to be able to pay my rent and I'm going to be homeless. And then my car is going to break down and then I'm not even going to have heat in my car. And they just kind of spiral this huge catastrophe. So with the decatastrophizing, again, we're saying like, let's realistically think like, you know, if your boss calls you into the office, like, I guess I would start with, did you do something that your boss would be calling you in the office for? And just kind of, like help them get to the point where they realize that not everything's going to go to the worst possible situation. And then we also have schema therapy, which targets deeply ingrained emotional distress and dysfunction. It helps individuals meet unmet emotional needs. It identifies negative behavioral patterns and replaces them with healthier ones. It also encourages self-worth, nurturing relationships, and personal growth. Key takeaways from this slide would be outpatient therapy is preferred. However, if safety is concerned, we might require inpatient. Remember that your borderline personality disorders are at a higher risk for suicide. Cognitive behavioral therapy and dialectical behavioral therapy are effective for personality disorders. I didn't talk about dialectical behavioral therapy, but just to kind of put that out there, dialectical behavioral therapy was actually designed for borderline personality disorder clients. It helps focus on their distorted thinking and their distorted behaviors, and it addresses kind of emotional regulation. Since its creation, it's now implemented for um, many other patients than just our borderline personalities. Group therapy can improve social skills and assertiveness, and then the schema therapy addresses deeper emotional patterns and past traumas. And that is the end of this video. The next video, I'm going to go more in depth on each personality disorder, what the clinical picture would look like, and what care for each of those disorders will be. And then we'll finish it off with some age-related considerations, mental health promotion, and self-awareness.